My name's Lisa. I'm 45 years old, and I've had vein issues for about 15 years now, and after I had my second child, they became very painful and you could see them, clearly see them, and I have a job that I'm lifting all day long and standing on my legs and on my feet for 8 to 10 hours a day. And I would get home, I would sit down, and I could actually feel my heartbeat in my legs. It was horrible.
If you experience discomfort, swelling, and varicose veins in your legs or ankles, you may be suffering from superficial venous reflux disease. Approximately 25 million people in the United States suffer from this condition. Varicose veins are caused by damaged valves, which result in backward flow of blood in your legs, a condition known as venous reflux. This can cause blood to pool in your legs and lead to symptoms such as pain, swelling, and varicose veins.
I was at my dermatologist appointment, and he actually said, "You know, Lisa," he was kind of looking at my legs, he goes, "Oh, I see you have varicose veins." He goes, "There's a sign out there saying there's a free vein screening." He goes, "Why don't you check that out?" And I was like, "Well, that's not a bad idea," because I've been thinking about it, but you always put things off. So the next day, actually, I made the phone call.
Superficial venous reflux disease can be progressive. Symptoms may worsen over time if left untreated. By seeking treatment, you have taken the first step toward recovery from these painful and unsightly problems. Traditional vein stripping surgery has been the only option available to treat venous reflux, an underlying cause of varicose veins. Vein stripping includes incisions at the groin and calf. A stripper tool is threaded through the diseased vein, and the vein is then pulled out of the leg. This can result in pain and bruising for the patient during the 2 to 4 week convalescence. Now patients can be treated with the closure procedure, a minimally invasive alternative to vein stripping surgery. Closure utilizes radio frequency energy to heat and seal the vein shut. In one report, 98% of patients surveyed who have undergone the closure procedure are willing to recommend it to a friend or family member. Recovery time is very short. Most patients return to normal activities typically within a day. If your physician feels that you are a candidate for the closure procedure, here is what the preparation for the procedure will be. Using ultrasound to scan your leg, your physician will determine where superficial venous reflux is present and map your vein. The closure procedure is performed on an outpatient basis. Using ultrasound, your physician will position the closure catheter into the diseased vein through a small opening in the skin. The catheter delivers radio frequency, or RF energy, to the vein wall. As the RF energy is provided and the catheter is withdrawn, the vein wall is heated, causing the collagen in the vein wall to shrink and the vein to close. The closed vein is left in place and over time is reabsorbed by the body. Once the diseased vein is closed, the blood is rerouted to normal, healthy veins.
I was nervous, very nervous, and I talked with Sue, and my issues with the symptoms, my heavy legs, the tiredness, and then Dr. Dubek came in and I talked with him about the same issues with my legs. The girls up front took care of all the insurance information, which was great. I didn't have to deal with anything with insurance. So everything was okay. I had a series of 3 months worth of procedures. The doctor and Sue and the nurses are awesome. I felt so comfortable when I came in. They explained everything in detail. And any questions I had, they didn't make you uncomfortable asking. It's pretty much pain-free. There's a little discomfort, but not much at all. A little tugging and pulling is what it kind of feels like. I wasn't even nervous. At the first one I was, but then the second one, after I knew what it was like, I was excited just to get in here, get it done.
Following the procedure, a simple bandage is placed over the insertion site. To aid healing, your doctor may also wrap your leg or provide compression stockings for a short period of time. Your doctor may encourage you to walk, avoid long periods of sitting or standing, and refrain from strenuous activities for a while. The closure procedure allows you to get back to normal routine activities, typically within a day, with minimal to no swelling, bruising, or scarring.
After the first procedure, I felt good, and then it just kind of, each one progressed, and I'm just like, oh my gosh, you know. I asked myself many times, my husband says, aren't you glad you went in? He goes, why did you wait so long? Because he would say things too. He would comment to me, and I'm just like, oh, you know, this is how it is. The worst part is putting on the stockings. That's the hardest procedure of the whole surgery. I did mine during the summer. It was a very warm summer, but it was worth it. Every bit of it. Every bit. I took 2 days off. I took the day of the procedure and the day after, and then I worked after that. I just wore the stockings, and I was very comfortable. And you know, if I had any questions, they left the door open. You can call anytime. And I did. One day I was a little nervous. I had some burning, so I called right away. Within probably the hour, Sue had called me back and explained what was going on and said if I feel this, any kind of certain feeling, to call back right away. And I was very comfortable with that, and I'm happy to say everything was fine.
In a comparative trial, results were in favor of the closure procedure as compared to vein stripping surgery. Key findings indicate that patients who underwent the closure procedure experienced significantly less post-operative pain and bruising and returned to work more than a week earlier than vein stripping patients. The closure procedure has proven to be highly effective, with more than 90% of veins treated remaining reflux-free 2 years after treatment. Patients report rapid and pronounced relief of venous reflux symptoms in legs treated with the closure system.
So then now, a year later, I have so much energy, and I can't even, I say this so often. I say to my family, I am so blessed to be able to have this done, this procedure. I can run again. I trained for a marathon, and I ran my marathon in 4 hours and 20 minutes.
Physicians may recommend other treatments, including sclerotherapy or surface laser treatments to address visible spider and varicose veins. To treat tiny purple or red veins, often referred to as spider veins, your physician may perform sclerotherapy. Using a series of injections, your physician will deliver a chemical solution within the vein. The solution damages the inside of the vein wall, causing them to close. Multiple treatments of sclerotherapy are usually needed to achieve good cosmetic results. The closure procedure has been successful for treating appropriate patients with superficial venous reflux. Follow up with your physician to determine the best treatment for your condition.
Veins really come about as a result of a multitude of reasons. People develop problems with their veins, you know, in some ways because of their genetics. And probably for men and or, you know, prolonged standing, those are really the two reasons that men tend up getting bad veins. For women, it can be different. Estrogen is a relaxing hormone, and so the presence of estrogen makes this a disease that is more common in our experience in women than men, but only slightly. Pregnancy significantly adds to the space-occupying baby, and the pelvis pushes on those veins, and that really sets off people that may have been doing fine or have some vein disease, but pregnancy really does set people back as far as what happens to their veins over time. And so it is prolonged standing, genetics, veins, and for some people maybe it's just bad luck. But in general, we treat veins from A to Z. We treat little tiny spiders, and we treat people with open leg ulcers with their vein disease. We have gone through the process of what is called ICAVL certification in order to get to do this. That required submitting our quality guidelines and becoming an accredited vein center. So it's a rare thing to do outside hospital situations. And so I'm the medical director of the Vein Center, where it required training. My training was at University of California, Davis, for on-site, where they look at our numbers, they look at and evaluate our reports and make certain our reports are up to standard. And we develop even partially our own system of a very colorful graphic representation, so that when we do the ultrasound at the end of it, we can actually take and use a color map and show patients exactly, again, that very detailed ultrasound, how detailed it is. And so what we do, our quality guidelines, And the fact that we're a certified vein-only, this is not an arterial center, vein-only center, that we're certified, and that's a rare situation for a vein clinic. Even for vein clinics that call themselves vein clinics, most of them aren't certified. We look at the leg anatomically and think of the leg as a ladder. And on the ladder, there's a stave on either side, and we see that the staves that go up and down are the parts of the ladder. There's a part of that ladder that's deep and inside the muscle. We don't treat that because treating that inside the muscle is very complicated and it isn't done well. And so if somebody has insufficient veins of their deep system, we have them exercise, we have them wear support hose, but there's not a lot of treatment to that. We treat the skin system, the stave that's at the side of the skin, where when the vein blood runs, instead of going up the leg in the vein, being caught by check valves, it actually flows backwards. And again, prolonged standing, bad genetics that make you weaker, history of pregnancy or multiple pregnancies, all of those tend to make the valves function poorly, and then the blood flows down the leg. And when that happens, people start to develop problems. What are problems? People don't even know in many situations that they're having problems. They've lived with their heaviness of their legs. They think that at the end of the day that everybody in the world has particularly heavy legs, and they don't realize that 20, 30 million Americans are walking around with very significant venous disease. And so patients tend to minimize their symptoms because this doesn't happen like they were fine yesterday and now I've got this disease. This is something that sneaks up on people over a period of years. And so people end up with heavy legs because their superficial system at the level of their skin, that skin level stave, is dropping the blood down into the leg, and it's pooling at their ankles and pooling in the skin, and it doesn't flow out of their legs particularly well. As a result of that, their legs get heavy, they can get edema and swelling, and then in some situations you can see the veins poking out through the skin. In many situations, there's not a lot to see on the skin. Historically, we only treated patients if you could see their veins, and gosh, we can see your veins so we can treat your veins. What we know is that the real way to determine whether somebody's got really a fairly significant venous disease is to look underneath their skin. And obviously we can't do that with our naked eyes, and so we need a high-tech ultrasound. And in our practice, we have two very expensive and accurate ultrasounds with wonderful staff that operate that are registered vascular technicians and only spend their time doing venous ultrasound. And so the staff that we have that deals with the ultrasound then is able to tell us with an exquisite three-dimensional map what is going on inside somebody's leg. They can tell us about perforators. Okay, so I talked about the leg as being two staves that run up the length of the ladder. Now there's rungs that connect each of those staves. The way the leg works, the blood is supposed to go from the skin system into the deep system, inside the muscle, so that when you then walk and contract, the blood, because of that muscular effect around the vein, shoots the blood up the leg. The blood will actually go from the deep system, they contract their leg, and the blood shoots into their skin system and makes their skin insufficient and makes their leg heavier. And so if you don't have a wonderful ultrasonographer that can tell you that what's going on with that connecting rung, we'll call those perforators that connect one system to the other. If you can't tell that, you could do the wrong operation. And so we rely extensively on our RVTs, and when we do ultrasounds, we really want to know in detail the entire anatomy of the leg. There are veins that many other people, when we had previously had sent people out to a hospital, we got an ultrasound report that just didn't see what we're seeing. And so we know that we are seeing more and treating more, and I will argue better than many other practices. We've done thousands and thousands of these procedures in our practice over the last 8 years, and so we have such an extensive experience. We then take care of these veins. To get this all covered for people by insurance, there's now a scoring system. And insurance companies are unfortunately going to be more and more restrictive about what they will allow. And so the system they're using now is called the Vein Clinical Severity Score, and something else called CEAP, which is a determinant that if you don't have swelling and if you don't have pain, insurance is not going to cover the treatment of varicose veins, because a lot of people are saying, well, I'm treating varicose veins, but they're really not. And so you really have to have documented pain and or swelling for patients to fit. And so patients tend to minimize what they have. Somebody will say, and in fact, there was a very well-known speaker from Mayo Clinic that just spoke at the vein seminar in New York. He said, I didn't realize I had pain. I didn't realize I had heaviness till I had my legs treated and the heaviness went away. So people who spend at the end of the day, who put their legs up and their legs start to feel a lot better, may have heaviness and swelling and pain. They just call it discomfort. They don't call it pain. Well, on the Vein Clinical Severity Score and on the SEEP classification, to be covered by insurance, you have to fit the criteria to be at least SEEP 3. SEEP 1 and 2 will likely not be covered by insurance. So then we get patients, we see them, we talk with them about what their symptoms are, we have them see our ultrasonographer, we look at where their disease is, we submit a prior authorization to insurance, and the insurance is going to ask us a couple questions. One of the questions they're going to say is, what has the patient done to help themselves? What have they done conservatively? Have they taken Motrin or Tylenol or Aleve or aspirin or some other medication? It doesn't particularly make the process go away, but insurance companies will ask us that question. The other question they're going to say is, have they worn support hose? There is no particularly good evidence that say that support hose makes this disease go away, but many people's insurance companies is going to require at least a period of time where the patient has worn support hose. Almost every insurance company is different than every other insurance company, and so it depends on what your insurance company is going to say when it comes to determining whether or not they'll approve a procedure to fix your veins without a 4-week, 6-week, 3-month trial of support hose prior to moving forward with the procedure. Now let's talk about procedures. Now, again, I'm going to start from little bitty and spider veins that are cosmetic to much bigger veins. And so we have 3 technologies to deal with little spider veins. We have a radiofrequency needle that we put in, and under the skin, and with a foot pedal, we're able to make little tiny spiders go away. Number 2, we have a laser technology, and we have many laser technologies. But for spider veins, it really needs to be a very special, just because we have a laser, we don't use a laser. Finally, we use injections of medicines into the vein. The medicines make the veins clot off and go away over time. And so that's how we deal with the tiniest little veins. Number 2, the regular great saphenous vein, that stave, that longitudinal vein that runs down, or several veins that run down the length of the leg. Depending how tortuous or how straight the vein is will help us determine what technology we use. What we would typically do with a vein is determine its size, because the laser energy is designed for a smaller vein, whereas the radiofrequency energy, in our opinion, is better for a larger vein. Again, we don't have just one tool. We have every tool there is for treatment of varicose veins that is available in the United States. And so we will then, using a single needle stick at the ankle, we'll thread the fiber up through that, up the length of the vein, and we will then use that the liposuction technique I talked about will actually use local anesthetic, and will place that local anesthetic around the outside of the vein. What does that do? Well, the vein is here, and we've put a fiber through the inside of it, or a laser fiber or a radiofrequency fiber. If we turn that fiber on, it would be hot and very painful. And so what we do is we use the technique of tumescing. We inject a large volume of local anesthesia around the outside of the vein. When we do that, the vein squeezes down onto the fiber, and it's numbed. And so by doing that, we're able to then turn the fiber on and back it down the length of the leg, all the way from the groin, all the way out at the ankle, and by then turning on the heat, we're actually able to shrink wrap the vein and tighten it down. We can do that even through the skin with those perforators, those rungs that connect the superficial system to the deep system. We can get directly into that in a vein that's only that long. We're able to close those veins without needing to do an open surgical procedure. Everything I've described and almost everything we do to the 99% of patients we do in our office. We do it in the office under local anesthesia with added tumescent local anesthesia, a large volume of dilute anesthesia. You might think that would be particularly painful. It could be if you did it wrong, but by doing the tumescing so that we control where we put the local anesthesia under ultrasound guidance, and specifically having the ultrasonographer that did your original screening study have the same ultrasonographer be there when you have your procedure performed makes this so reproducible. And our ultrasonographer, and for lack of a better way of saying it, protects you from not being numb. And so if you're numb when we're doing the procedure itself is painless, to the point where people could be talking on the phone or actually watching the television we have up in the corner of the ceiling while they're having it done. Some people would worry that that would still be something they wouldn't really enjoy or like. And so many of our patients come to us to be sedated. So on the date of their surgery, we ask that they not have a big meal, because we're going to give them some medicines by mouth that we want to make it into their intestine instead of sitting in a cheeseburger. And so we say, if you need a piece of toast or something really light before you come in, you're going to come in towards the middle part of the day or later, eat really pretty light and come in, and then we give you patients an antibiotic, Valium, and some sort of pain medicine, and let that sit in their stomach for half an hour, 45 minutes. So they're really pretty chilled out and sedated when they have the procedure performed. That works really very well. Some people ask for a little bit more, and we give that to them. We have that available here. Because we are board certified plastic surgeons, we can't put an IV in and do this in an office situation, because our boards require that any surgery we do that's surgery with IV sedation or higher be done in an operating room. We really don't feel this procedure needs to be done in an operating room. We really believe that the 99% of patients can be done in an office setting. Somebody that has real emotional issues, or in some situations when we're putting the laser fiber directly through an open, painful ulcer, that somebody's come to us with this open ulcer, those are patients that sometimes we'll take it to the operating room to deal with. But again, the 99% of patients do exceedingly well with having this done in the office. And so on the day of procedure, they come here, they get sedated, we do this procedure, and they essentially walk out. When they walk out with support hose on, and we put that on them for a couple of days after their procedure. And then if they've taken the medications, they're not allowed to drive themselves home. They have to wait till the following day to drive because of that. Most patients can return to work the following day, maybe with some discomfort, but most patients are able to do that, and we allow people to return to athletic exercise like running 3 full days after the procedure is done. People can return to running. People feel their legs are less heavy right away. People feel that the pain is different, and even right away they say, yeah, I can tell I've got some bruising from where you numb me, but their legs feel much better. And so we've had an exceedingly high satisfaction rate for this procedure. To date, we have not had anybody with a significant deep vein thrombosis. What does that mean? These two veins are separate all the way up the leg till the groin, and then they meet where the deep system connects with the superficial system up at the top. We never want to clot the deep system because that's the main arterial or main gate or raceway out of the leg. And so we've not had anybody have this vein get clotted, and that's thousands of procedures. And so we've had partial clot that when we burn the vein right here, this one as it's coming in, we'll have some partial clot, but that always resolves. And so we've had no significant complications in our procedure in this procedure in the last 8 years. Minor wound problems or things like this, if we have to do special or more open surgical procedures, with people with very large veins, and I'm talking, size of garden hose veins, sometimes we'll actually do an open incision approach at the groin and tie that off first before we'll do the rest of this work. And so we do this very, very carefully. Our goal in this particular set of procedures is never to swing for the fences. This is hit a base hit, get on, hit another base hit, get on base again, and just keep moving in this game of baseball as you look at it like that. The goal is to not try and do all the vein disease in the entire leg in one operation and do that in a more risky situation. So what we much prefer is we will take care of this vein and maybe that vein in this procedure, come back the following week and look and say, gosh, that was successful. Now let's move to the next step. And so commonly we'll do this with 4 or 5 or 6 procedures between the two legs over a period of 2 or 3 months in order to get somebody completely cleaned up. And so by doing it that way, we think it takes longer, it takes more visits, but there's no lost time work except for the time that a patient is here having the procedure done, and that day when after they've taken medicine they don't want to go back to work and they can't drive. But otherwise people continue working and get on and get back to this. When you do it with the open surgical technique or try and strip out or rip out the vein, which Dr. Dubik and I know how to do, but choose not to, that's 6 weeks off work, significant amount of discomfort, and in many patients long-term pain. There are many other little techniques, stab phlebectomy, which we do, perforator ligation, branch ligation with lasers, and again we have 2 different laser technologies that we use for the vein that are useful, that aren't worth spending the time discussing in this movie. A lot of people at very different ages are embarrassed by the way their hands and feet look, and that includes spider veins on their ankles and large veins. When people are younger, they tend to have more fat on their body, and as we age, we tend to lose that fat. And one of the signs, telltale signs of how someone is aging is to look at their hands. Many people have decided that they'd like to have the size or distribution of their veins diminished. And so we have techniques of injection, and we do this again with ultrasound guidance. We're able to inject a relatively non-toxic medication into the veins and shrink the veins on the backs of hands and on the tops of feet and around ankles so that we can actually improve the way things look. Typically insurance won't cover that, but we treat spider veins on people's noses and cheeks and faces just as we treat that. And so letting you know that we do the insurance thing and we do the non-insurance thing, and we think both are important based on what any individual person's needs are. Patients do particularly well. 3 weeks to 3 months of support hose ahead of time, a couple of days of support hose afterwards care if you're flying in airplanes after this with needing to get up and walk around to avoid clotting, and a very high patient satisfaction rate. And so as we look at our patients longitudinally, we've found that patients just end up saying, just thank you. I can't believe I lived with it for as long as I did, and my legs feel so much better.
The quality of life is unbelievable. I mean, I feel better at 45 than I did at 30, and that's the truth.